Welcome to another edition of the Deals for Dentists podcast. And today we're joined by Dr. Eric Pulver and Dr. Jeremy Krell, and they're of Denti.AI. And Jeremy, you're zooming in from Jersey City?
I'm now in central New Jersey.
Central New Jersey. Okay. And Eric, you are you're in Chicago area?
Chicago area, yeah.
Okay. Well, you live in Chicago, but you practice
in Northwest Indiana. I'm sorry I jumped in there. Yeah.
All right. So Jeremy is an advisor at Denti.AI, and Dr. Eric Pulver is the chief dental officer. And you can go to dealsfordentist.com and you can get a free trial, which is a beta testing at no cost. Just mention Deals for Dentist, and you can get a free trial. So guys, thanks so much for joining us.
Thank you for having us, Eric.
So I just wanted to start with exactly, if you guys could explain to the audience exactly what artificial intelligence is and how it helps dentists.
Interesting. You know, artificial intelligence is something that I often find I have. It's, you know, I think I know something and then I want to learn more about it and I realize I didn't really know what I didn't know. And artificial intelligence is a way of using algorithms for decision making. And we often don't analyze that evidence-based decision making process. And I think that it helps us to be more accurate and confirm our decisions without noise or without bias. So artificial intelligence is that the step of automation of certain processes that help us to make more informed and more accurate decisions. And it also brings awareness to the fact that we're not as correct as often as we think we are, although we all, especially in the dental profession, you know, strive to perfection and strive to constantly learn. I look at it as it can be a friend. It depends on how we look at it and how we usher it in and how we guide it and how we teach it.
Yeah, I agree. And I really think it's about helping us be better clinicians and providing better care for our patients at the end of the day. You know, and on top of that, it's become in the dental industry sort of a pretty broad and ubiquitous term that applies to many different types of or uses of AI within dentistry. So there's a lot of different opportunities out there that help us in different ways. It's not all just lumped into one amorphous blob. It's multiple different, you know, very discrete use cases. And so we should look at it as you know, a very multi-dimensional, you know, multi-pronged approach that can help us in a lot of ways.
So tell me how your software works. Does it integrate with the practice management software system and the X-ray system? Like personally, I have Dentrix, I have Dexis. Can you explain how that works? And does it actually read the X-rays and point out areas of concern?
Yeah, we're looking for a fully integrative solution is kind of our vision and our goal. And with any vision and goal, you have to start with baby steps. The beta version that we mentioned before that's available on our website isn't an integrative solution, but it is a standalone, which is kind of interesting because you can use that to help identify findings. We're very careful not to say that we're diagnosing because the doctor diagnoses, right? The doctor makes the final decision with the help of the hygienist, you know, and as a team, it doesn't take the place of that, but it helps identify things. So we do have a fully integrated version that will read and then write back directly into your Dexis or Ascend or Open Dental or Denticon, a number of different solutions where we can use this as a plugin, like an application, rather than a whole system that you have to purchase. So it should work seamlessly into your practice management software systems. And that is sort of in that user experience, user interface world that we're working in now. And we can get into this later, but we based our findings and the algorithms on academic validation, which took quite some time. And we have been received certain awards for that in the industry as well, which as a clinician, I think, you know, I'm particularly proud of and excited that we have that solid basis. And if that's one thing together to push AI across the board from all players to allow it to be adopted, that's a really important place to start.
Now, ultimately, does this act as just like a great second opinion? If you're evaluating X-rays, like you said, the dentist is diagnosing with the help of the hygienist, and a lot of times the hygienist is the one taking the X-rays. But is this really just like kind of like a companion there, helping you diagnose and giving you that second opinion that you need?
I think it sort of has benefits for multiple parties within the practice, right? It certainly helps the clinician as an aid, to remember to complete your charts, to, make sure to catch all of the, the findings, all the information that's captured within an X-ray. It's just a two-dimensional image, but it's rich with information, that they really want to capture. It's an efficiency tool, right? It really helps to, capture that information and translate it into the chart with our auto charting feature. It very much is a helpful aid to kind of the hygienist or the dental assistant who's exposing the X-ray. It will indicate to them a high quality image versus a lower quality image, and it certainly can be used as a quote unquote second opinion, in terms of providing a report, an educational report to the patient, and giving them that extra degree of confidence that, these findings are not just, findings seen by, kind of the naked eye alone, but also, kind of confirmed by technology.
Yeah, I think that's well said. One of the analogies that I'll often use is how do we make our decisions? And Daniel Kahneman, who is a economist and Nobel Prize winning author, Think Fast, Think Slow, describes the different methods we use to think. And when we think quickly, we're using our reticular activating system. We make a quick decision that's based on our gut, and we're pretty confident we're right because it's a quick one. But he also shows that we haven't analyzed things, and those decisions are often not correct. And we can look at that as the decisions that we make every day in a busy practice. And those decisions are biased based on kind of our beliefs. But in a new book he's coming out with, or may have just been published, called Noise, he talks about the things around us that influence our day-to-day decision making. So were we pulled over at a red light? Do we get a ticket? Were our children loud in the car before we dropped them off to school? Is our second patient late, and now we have 3 patients in the room? What are the influences that are making us make a decision? So Eric, when you talk about a second opinion, it helps us like that, but it also helps us to assure that we're not missing things, and we're also more accurate with the decisions. And I looked into the Google self-driving car work. And when you look at what they did and how they describe it when they're talking about it, they go, well, the first 10 miles are really hard, and then we got 100 miles and we learned more, and it was about getting around. It was about getting there safely. And then we got into 100,000, and then 10 million, and then 100 million miles. And now all of a sudden we have all this data that allows this machine learning part of AI as it gets smarter as we get more data in. And if we train it with the top minds, it gets, it's a good basis to start from. So when you're at a light and you start to go, but the light is still red, or somebody else is shooting across an intersection because they didn't see that the light was red and they were going to hit you, and your car stops and doesn't let you go, or the self-driving car stops and the human missed it, how many accidents do we have from red lights or orange lights or green lights or stop signs that we have that now we're learning from? So now it's not just about getting to places safely. It's about how do we get there more efficiently? How can we guide the traffic so we can get there more quickly? And these are the things that we're at a process early on in that self-driving car in dentistry. And we have this exciting opportunity to participate in teaching and learning and embracing and bringing it to the marketplace in a safe way that we hope we can be a part of, our providers can be a part of, our payers, insurers can be a part of, our industry leaders can be a part of, and we can help fix the face of oral health care and maybe push us beyond into oral systemic health links and redefining our role as oral health care providers in the general wellness space. So a lot can go from this first interpretation, but we have to get it right at the beginning, right?
I think Eric makes a couple of really interesting points there. First of all, he brought up Kahneman. If you haven't read anything by him, super interesting work. It's really cornerstone research. I did my MBA at Chicago Booth, and there's a lot. It's really kind of some of the subject areas. I did a concentration in managerial and organizational behavior as one of my concentrations, and that really is kind of where economics meets psychology, right? And he's a big name that comes up in a lot of that space, and some of these same concepts, really, frankly, precede all of the AI, machine learning, computer vision type technologies that are advanced technologies, sophisticated technologies that we have today. A lot of these same kind of theories have been in place and known for a long time. And it speaks to a lot of heuristics and biases, that humans have. And, another one is, frankly, we're not good decision makers when it comes to, multi step or multi-factor decisions, right? The human mind is just not programmed like, a computer with multiple CPUs to process that, right? And so we tend to get into decisions, and make moves that aren't always, the most optimal moves, right? We're all trying to do our best as clinicians, but, using technology like this can optimize, the work that we do. And so I think a lot of that research rings very true, at least to my ears when I see it kind of enter, that behavioral science element that's behind, AI really, enter its way into dentistry of 2021. And I think the other important point Eric made, or another one that he made, was around the industry as a whole, right? I mean, AI is going to be what we make it, right? By definition, we have to train it, right? So it's what we put in is what we get out. And so it really, ultimately will be as good as, this entire industry understands it, accepts it, supports it, and helps to build it, right? As kind of a resource that we can all use. And, I think it's worth, kind of a call out here to, some of the great work being done by the Dentistry AI Council, not just the individual companies like Denti.AI that are within the dental industry, but now we're starting to see an organization to centralize some of the ideas coming from each of those companies, as well as from stakeholders around the industry. And right, that really is kind of the start, of a broad, kind of industry approach to implementing a technology like this.
Now, you mentioned the self-driving car, and after 100,000 miles or a million miles, it gets smarter and more efficient and better. How many X-rays has DentiAI analyzed, and at what point did you start to see that crossed that point where it was starting to get efficient and learn?
It's a great question. I found that really fascinating when I first saw that in sort of real time. I was back in Toronto, where I'm from, and our headquarters is in Toronto. Dmitry Tuzov is the founder. He came from Russia and he moved to Toronto through a creative destruction labs, which was an incubator, really spectacular incubator, particularly with AI based out of Toronto. And when I first met them, they had already developed written a paper which was about to be published with Michael Bornstein, who was at the University of Hong Kong, a maxillofacial radiologist, but he's now back in Switzerland now. But at the time, they had published a paper based on hundreds of thousands of panoramic images, and they developed an algorithm. It came out of the 3D space, and then they went into the 2D space because it was more common. And it all happened after he had an issue with a tooth. And he said, wow, why can't I maybe figure out how to get my algorithms to find the canals in the tooth that were missed, that led to a failure in a bone graft and an implant. And he was in the 3D space at the time. He had done a number of other things before that, but that was where he was at the time, where he had an issue with his tooth. So he started looking at that. There wasn't a lot of research being done in oral health and dental. switched his focus on his PhD into this space, and developed the automatic charting concept where you can identify and number teeth off of a panoramic image. We can do that, by the way, off of a PA and a bite wing as well, which is pretty cool with the metadata built into the image. But getting back to the question, so they started working with annotators to create that project before I met them. And by the time I started getting involved, and we were in now North America, and we were getting North American validation sets from University of Louisville and UNC, we started seeing that some of the annotators that initially had been used all over the world were not as accurate as the algorithm. So they could only use certain annotators. And what was interesting, based on their geographic location, some people were more likely to find decay, and some people never found it. And it was really ironic how different it was. And even some of the research that the AI Council recently put out showed a similar type of research, where they used a bunch of practitioners in multiple different countries, and people just didn't agree. So we don't agree with each other. We have parameters that we learn in dental school, but then to bring them into the field and to look at an x-ray, we often disagree with each other, and we often disagree with ourselves if you wait 6 weeks. So it's kind of an interesting space. So we've seen that change. We've seen that the machine will get better and better. And at this point, our initial study at Louisville used 18,000 images, of which we took 2,000 out because people wrote names on them and we couldn't de-identify them. So we now have, I would say, in the millions of images that have been utilized to work with. And we're always tweaking them up. We're looking at, bone loss. We're looking at so many different aspects, but not just identifying them, taking it to the next step. What's meaningful data? So we find that, how does it integrate with a billing code? How could it help with your insurer? How could it help with inventory, with ordering components, with looking at risk assessments, with determining where to do precision education across a network in a big DSO or in a dental school? So how can we really become better at what we do from doing it? And if I look at it, I can't help but thinking back when cars came around and there were horses, right, on the road, and somebody wanted to stop at a sign because it was getting busy. Someone would hold up their stop sign, or they'd go and they had a light. Eventually someone said, I'm not standing by the light anymore. I trust it, right? But it took a while before you started to trust it. And I think that we're in that early stage that one day the routine things, the quick decision-making that often can be go wrong, will be trusted as a team member, not just a second opinion, but a team member on our team to provide care. And the digitalization process, which we hear a lot of, oh no, everything's going digital, may allow for more analog relationships to return between the doctor and the patient, and more time to talk and discuss things with them and have more clarity. Yeah, sorry, Jeremy. Yeah, so that's kind of.
Yeah, I just wanted to add on to what Eric said, just to create an important, I think, distinction on top of that maybe in some dentists' minds, which is, you always hear this statement, right? You ask, three dentists about, a fairly comprehensive or complicated case, and you get 5, 6 different treatment plans, right? I think we all kind of chuckle when we hear that. And, AI is not there to stop that level of innovation or creativity, because there often are. That's why we have informed consent, right? There are alternatives, in terms of treatment, and you try to find the one that's right for the patient. Where AI steps in is in helping, find something that was missing, right? A treatment that we didn't bring up because we didn't, see the root cause of it in the first place, or, the treatment plan that gets in there. So, complicated case, 3 dentists, you get 7, actually 6 of them are good treatment plans, but the 7th is an outlier, right? So I think it comes in and, really helps on the fringe, on the one side, finding things we didn't find at all in the first place, and the other side, helping to dismiss outliers that aren't really, really at play, but it is not there to constrain, the alternatives and the innovation, the creativity that, essentially a dentist who is, very much an engineer of their own art, has in the care for their patients.
Yeah, you mentioned, both of you mentioned, different dentists giving different opinions, and also within yourself, there could be three different Jeremys or Erics. I'm fresh in the morning at 8 a.m. 5 p.m. I'm wiped. I could look at the same X-ray at 8 a.m. and give it a different, diagnosis than I would at 5 p.m. And that's within the same person. Also, I could have just come, from an exhausting procedure, and then I'm going into the hygiene room, and my mind is still with that patient in the other room. But I can't let when I'm doing the hygiene exam, I can't let them know that. But I could miss something because I'm not as focused as I would have been if I, had that patient in my chair for half an hour to look over their X-rays. So it takes that, I guess, that human error, even just within us, out of the equation. And you could also have, the emotional bias, a patient that's really phobic and they're saying, please, doc, don't find anything. I'm so nervous. I don't want to have any dental work done. Or you have friends and family in the chair, and, so all these factors, like you were mentioning, Eric, the noise, can really influence your a dentist's diagnosis, especially when they're in a busy practice.
More than you think, right? And it's not something that, just kind of goes away on its own, right? It's not something that we can say, well, I've practiced a decade or 2 decades or 3 decades, so I'm aware of those things and I've overcome them, right? It's more, we're all human. We're not computers. So working with computers, at least in theory, should make the total outcome, right? The care for our patients better.
Yeah, I think that it comes down to thinking a little bit as to how do we define ourselves, and what are our wins, what's success, what makes us happy, and in doing that, you surround yourself with people that might be pushing the envelope, learning new things, or maybe you surround yourselves with people that are very similar to you, so you're not kind of threatened to do those things. They're not threatening, may not be the right word, but you're more comfort in that bubble that you live in. And I think that, I don't know that as you go through dental school, and this is no downside to the maxillofacial radiologist, because some of the work that they do is just unbelievably spectacular, and the innovation and things that they're working on to show us better imaging and able to help us with our diagnostic findings and support. But as oral healthcare providers, we're so busy doing so many different things, including being an expert radiologist, and then we're doing our surgical procedures on, whether it's a crown flap or a third molar case or an orthodontic case or whatever it is. We're doing our surgeries, we're doing our diagnosis, we're, HR people. This year we become accountants and, infectious disease experts, and who knows, right? So do we define ourselves on our ability to catch every little bit of decay? And we know that on an X-ray that we look at with the human eye, maybe we got 32, 33 shades of gray we can see, and a computer has 256. So it's not an even playing field.
Mm-hmm.
It's not even, it's like, so we should say, hey, well, what can we get some help with? And be a little humble and open to seeing how it can help. And for those of us that say, hey, this isn't good, this doesn't work, we need those people on board to say why it doesn't work, so we can make it better. We need to have everyone involved to really shape it and guide it in the right way. So I think it depends on what you're looking at and how you define who you are. Is it on your radiographic interpretation on a PA of decay, or is it on your ability to document or measure quality of care and maybe outcomes? And demonstrate value in what separates your ability and your skill set, your continuing education and your office culture from someone else's. And it doesn't really have to be a Google review. It should be a true outcome with data. And one day, through the window of radiographic interpretation, it would be really cool if we could jump into a more transparent healthcare system that can show the data in a true way to build trust and to build, what dentistry is all about, that social contract, the trust that we have with our patients, to not have multiple different things coming out of the same dentist or even different dentists. So how can we redefine? How do we pivot? How do we change? And maybe with COVID and this digitalization and the world looking at things in a different way, this could be a good time for us to get together collectively to make that change. And I believe AI is a big part of it.
And echoing a couple of things Eric said and kind of showcasing at the same time, some of the features of AI, right? We know how hard it is to pull out, diagnostics as clinicians with the difference in grayscale, like Eric mentioned. And there's hundreds of potential findings, both existing and new, that could be on a radiograph. Try looking at it compared to the last set, right? How many times do we do that? We often do that, right? We look at, well, did it change? Right? Let's take a look. 6 months ago, a year ago, was there a change? It's hard enough to see the problem in the first place on the first. It's hard enough to find the time, right, in the busy schedules of a hectic office. To look at the one X-ray and do a really high level job, but then to compare it accurately to one before that is slightly different positioning, slightly different angulation, slightly different coloring. There's a lot of factors there, that are very, very tough to account for. And the other thing that I think is interesting about AI is not just showing kind of changes over time in dental, but also it really opens a big window to something I think Eric P likes to talk a lot about, which is that concept of oral systemic health links, right? Because you can have multiple types of AI, working in or multiple applications of AI working in tandem here, right? So you can track what's going on with bone level and periodontal health. You can track what's going on with the hard tissue health, whilst simultaneously looking at the chart, the data that's in the rest of the chart, right, with different applications of AI, right, and ultimately can kind of see, right, we see a lot of those studies being published now, periodontal health related to cardiac health and a variety of other health related features out there, right, to be able to actually kind of quantify that, and do so over a period of time, accurately, is a really tough thing to do, but AI potentially opens the door to do it. I do think mindset, how this industry views this type of technology is critical to its success and passing along the benefits to our patients. Eric drew a similar analogy. This one is potentially a bit morbid, but I don't think, criminal investigators, for example, think anything less of themselves because they have to use a canine unit to sniff something out, right? They're simply exploiting, the difference in, a better ability to sense something in the nose of an animal versus, of a dog versus of a human. We're doing the same thing here, a human eye compared to the computer's ability to view an X-ray.
Now, does it pick up, what pathologies does it pick up? Endodontic lesions, periodontal bone loss and periodontal issues, caries, all the above?
Yes. We've done our academic validation studies with Don Tyndall at UNC on periapical radiolucencies. We used a CBCT as a gold standard. So it definitely will pick up periapical lesions, which is really interesting because it'll find it quite early. And even if you don't see it, and then you might address it and ask a patient, is it tender here? And as Jeremy mentioned before, you can look at progression instead of being like a gut feeling. You can look at the difference in the probability of the finding being present over a 3-month period. So maybe you'll think differently about an abutment tooth or a bridge, right? And you'll say, hey, is there something here? And you'll look again. You may have otherwise overlooked it. caries is what we studied at University of Louisville. We found that incipient and early decay was found almost twice as likely by the AI than the maxillofacial radiologists. So that was a very interesting finding. The big, gross, blowing out caries, we're pretty good at finding those. The AI sometimes misses it and says it's a missing tooth because the whole crown's gone. So those are optimization things that we have to work on. So you could point and go, oh, the AI is not working. Well, I've sat in a room with a large DSL at one point, and we were looking through, well, will humans rely on it too much? Will they not? Will they trust it? Is it going to be accurate enough? And we popped up a case. And it was interesting because the AI said it was, say, tooth number 4. And they said, well, it's clearly tooth number 5. And we all agreed in the room, but the provider called it tooth number 6. So when we put up tooth number 6, we were all looking at each other and going, well, okay, well, what happened there, right? Well, that was an exact situation that happens that unless you're in it at the moment with a bunch of different people, you sometimes don't realize. We can look at bone loss as well. We're looking at integrating into the AAP classifications, which would be very helpful. We can look at wisdom teeth. We can look at caries we mentioned. We can look at missing teeth. We can maybe make assessments for the ability to graft or not graft or implant questions. We can number teeth. So you can number a bite wing. You can number a PA. We find crowns. We can look at amalgam or composites. So we can differentiate between the two, and we can link it to certain codes in some cases as well. So, I don't know if I've touched on all the things that we're working on, but, you could, in your mind, and we've all done this, you write down a list and you can roll it across the floor, but you have to start somewhere and you have to validate it. And then you have to find the right champions and ambassadors and supporters to work through, that feel that it's worthwhile, so we can get past the beginning to make it the user interface and make it the streamlined flow work well in a practice. So for some people, they love getting in early like that, and others, they want it more refined. And there's no right or wrong way, but it's one of those opportunities that I personally, I know Jeremy is, perhaps yourself is excited about, because it's something that one day we'll look back and go, hey, when did that all happen in dentistry? And we're like, yeah, my grandfather was part of that, or which is us one day, but that tomorrow's today, right? It's going on now. So
yeah, and I think to make it super practical for listeners, right? Eric brought up a point about spotting that periapical radiolucency early, right? It's that widening of the PDL that we all know about. I mean, widening of the PDL can be really difficult, to spot accurately, spot time over time, spot on different teeth, spot with different angulations, right? That's a challenging one, and yet, the impact is pretty profound if you're able to catch that early. You can really, stop the diagnosis, stop the progression to a higher diagnosis, right? Where you actually have to take action. And so I think it's critical, to see that coming. And I also agree with Eric. I think, the AAP classification is a big one. Our classifications are always changing, as an industry, and then there's always difficulty with transition, and doing something like measuring to various anatomical landmarks, as a pure measurement versus a percentage, of different ratios like crown to root. That can be a challenge. It's not the way we necessarily thought about things for a long time, right? Transitions are hard for all of us, but the computers can really help that, and can really make that easier for us.
One thing, Eric, I just wanted to throw in one quick thing, if it's okay, is that we also use voice in an interesting way to help with the efficiencies in the automated charting as well. We found that the automated charting helps to streamline the efficiencies in the office, and there's a lot less contact, and there's built-in efficiencies that reduce the time to chart and to document. And so the documentation's earlier, faster. Well, I mean earlier because we find decay earlier, which might lead to less expensive care for patients. We also speed up the time for documentation and the patient visit because we're more accurate. We speed up that time. And then getting back to that other point is that the amount of information coming at us now is so exponentially huge. They say that the medical knowledge is doubling every 72 days. So how do we keep up with all this stuff? It's impossible, right? As an oral surgeon, I just have to do oral surgery. I don't have to do everything like my restorative general dental colleagues. There's so much information. I don't know how it can be done, right? So using, the radiographic interpretation and some of these things that we're branching off into to then bring in the data points of overall health and wellness to help us make decisions. It's a really kind of important, kind of almost an obligation or a thing we can all participate in making a change that I think will be very relevant for all of our health and wellness in the future. And it's almost at times now because we're collecting information so rapidly that we weren't able to before. How do we keep track of it? How do we use it so that we can provide the best care to our patients? And that's kind of where I hope we move to in the future.
Yeah, it would be great if we could really see, prior cases of other patients benefit the new patients, right? That's how we improve, the care that we're doing versus insanity, right? Which is repeating the same things and expecting different results. And AI can be a big player in helping to make useful information out of prior cases for new patients as well.
Now, does it give you a probability where I found one of the hardest things to diagnose early on in my career was cervical burnout versus caries. Will it give that second opinion and say this is a 50% confidence level or 75% confidence level that there's pathology here?
Well, root caries is a very hard thing to pick up on a bite wound, right? Is that what you're talking about?
Mm-hmm.
So how do you find that? I think we're going to have to look at intraoral imaging in different modalities and then overlay it onto the radiographic interpretation to do that. So I don't see that using radiographs that's going to help a lot if I'm clear on what you're asking.
But Eric, directly kind of to, I think what your question is about the feature set within the technology. We do have a sliding bar for problem. Mm-hmm. So for all of our, for any of the findings that it picks up, it will give you a probability sense. Mm-hmm. And then, you can, in fact, you can even filter out certain ones, below a certain threshold if you like, right? If you're not interested in, say the 30%, you can dump those out and everything below, but you want to see like 31% to 100%, you can do that, right?
Okay.
And it can also, if you don't get upset at it, it doesn't mean to not be nice, but if the X-ray is of poor quality, it will say, please take another image. So mm-hmm. If you have total burnout because of the way the image was taken, let's say, it might suggest that you take another image. It'll say unable to read. Please take another image.
And that's nicely. Yeah. Guys, this is awesome stuff. I mean, at some point we're going to look back and say, I can't believe we practiced without this. Like I tell my kids that I didn't have a cell phone until I was 25, and I definitely didn't have a touch screen until, much later on in life. Is this going to be one of those things where we look back and just say, I can't believe we used to practice without this?
I hope so. I really think it's going to be that and then some. It'll be like, the first cell phone that was the big phone. I still have one of those. I kept it, compared to the smartphones that we have today. And maybe in 3 to 5 years, our phone's just going to be built in, right? A brain neural net, that can just talk, I mean, my dad has one of those now. He's 85. He was a pediatric dentist. His hearing aids popped right into his phone, right?
Yeah.
Pretty good.
So
who
cool.
else imagine that, right?
Guys, thanks so much. Again, Dr. Eric Pulver and Dr. Jeremy Krell of Denti.AI. And you can go to dealsfordentist.com to find out how you can get a free clinical trial and beta test Denti.AI at no cost. Guys, thanks so much.
Thank you so much, Eric.
All right, we'll be in touch.
Okay.